heart failure into a truly actionable clinical framework. The brilliant structure we're walking through today was put together by Dr. Asafullah KMU IMS Kohat, and I have to say, it offers an incredibly clear, organized way to understand exactly why a heart begins to fail, and more importantly, what we can actually do about it.
Throughout this analysis, think of us as clinical detectives. We're figuring out exactly why a heart is failing, so we can lock in the absolute best course of action. When a patient presents with a failing heart, our very first job is to classify the causes and, this is absolutely crucial, distinguish the reversible etiologies that we can actually fix from the irreversible ones that we simply have to manage.
So here is our roadmap for today. We'll start with the core mechanisms of failure, move right into the clinical triage model, talk about fixing reversible causes, managing progressive diseases, exploring the mixed spectrum, and then we'll wrap it all up with a solid prevention protocol. All right, Section 1, Core Mechanisms of Failure. Let's understand the foundation. Hearts don't just fail out of nowhere, right? It all comes down to the 4 pumps fail concept. Basically, heart failure develops when one or more of 4 mechanical systems goes haywire. Whether it's the pump itself, meaning the myocardium is failing, the pressure, which points to afterload abnormalities, the preload, meaning you've got volume overload, or the pulse, which represents arrhythmias. These 4 areas are your root mechanical culprits. Catch which one of these is failing, and you are already halfway to your diagnosis.
Moving right along to Section 2, the clinical triage model, subclassifying the causes. When you're actually on the ward, you've got to categorize these underlying causes systematically. We triage every single patient into 3 specific buckets. First step, curable causes. These are things like reversible ischemia or tachycardia-induced cardiomyopathy, where if you fix the underlying issue, you completely reverse the dysfunction. Next, we have treatable or manageable causes. Think hypertension or inherited cardiomyopathies, which need ongoing chronic medical management to stabilize function. And finally, modifiable risk factors, things like diabetes, smoking, and obesity. For these, we have to hit lifestyle and metabolic targets to prevent initial onset or further deterioration. Now, to anchor this massive list of causes in your memory, you've got to rely on the master diagnostic checklist mnemonic: heart fails. H for hypertension, E for endocrine disorders, A for arrhythmias, R for rheumatic or valvular disease, T for toxins, then F for familial or genetic, A for acute coronary syndrome, I for infection or inflammation, L for lung disease like cor pulmonale, and finally S for structural congenital disease. Seriously, whenever you're facing a complex presentation, just run through this checklist mentally. It makes sure no stone is left unturned. Okay, Section 3, Fixing Reversible Causes. This is our Group 1 paradigm. Now, check out this crucial contrast between what drives heart failure depending on where you are in the world. The global leader, literally the single most common worldwide cause, is hypertension. The actionable target here is crystal clear: strict blood pressure control to below 130/80. Doing that prevents left ventricular remodeling. But if we look over at high-income regions, the leader flips to coronary artery disease. Here, the prevailing mantra is time is muscle. The target shifts heavily toward rapid reperfusion, early revascularization, and getting patients to quit smoking immediately. This breakdown is basically your cheat sheet for exactly what to target across 4 major categories to successfully reverse left ventricular dysfunction. In the cardiovascular space, it's all about early repair for valvular disease and strict rhythm control for tachycardias. In the infectious and inflammatory category, you've got fascinating targets, like prompt antibiotics for endocarditis or early antiretroviral therapy for HIV cardiomyopathy. Looking at metabolic and systemic causes, optimizing glycemic control in diabetes with SGLT2 inhibitors or normalizing hormones in thyroid disease can profoundly bounce the heart back. And for toxins and lifestyle, complete abstinence from alcohol or pulling the plug early on cardiotoxic chemotherapy drugs can trigger massive recovery. The whole theme here is decisive, rapid intervention.
Next up, Section 4, Managing Progressive Diseases, the Group 2 paradigm. So, what happens when we can't reverse the damage? For these Group 2 progressive diseases, the reality gets a bit more serious. Our focus has to shift from curing the patient to managing symptoms and stalling the progression. We use a stepwise approach for this. It cascades from guideline-directed medical therapy, or GDMT, up to device therapies like implantable cardioverter defibrillators and cardiac resynchronization therapy. If the heart is still failing despite all that,
We escalate to left ventricular assist devices, all the way down to the final option of heart transplantation.
Let's look at the specific etiologies driving this progressive decline. We're talking about conditions like cardiac amyloidosis in the infiltrative group, or genetic cardiomyopathies like hypertrophic and arrhythmogenic right ventricular cardiomyopathy. These fall heavily into this irreversible group. You also have complex congenital structural diseases. Because we just can't reverse the fibrotic or genetic damage in these cases, our immediate focus has to be on stalling the disease with aggressive GDMT and advanced therapies, rather than fruitlessly attempting a cure.
That brings us to Section 5, the mixed spectrum, where time literally is muscle.
This is a fascinating clinical gray area, and the stakes of early diagnosis here are absolutely massive. Some conditions aren't strictly curable or progressive. They exist on a spectrum. As you can see moving across the timeline here, early diagnosis of these conditions gives you high reversibility. You can essentially pull the patient all the way back to baseline. But if you miss that window, well, a late diagnosis basically guarantees permanent structural remodeling. It crosses an invisible threshold from curable right into that progressive group 2 category we just talked about. To really master this mixed spectrum, just remember the SCFCIM mnemonic: sarcoidosis, Chagas disease, Fabry disease, chemotherapy-related cardiomyopathy, iron overload, like in hemochromatosis, and myocarditis. These 6 conditions are partially reversible, but only, and I mean only, if you intervene early in the timeline. For example, if you catch iron overload early, phlebotomy works absolute wonders. Catch it late, the heart is permanently fibrotic. The timeline is literally everything. Finally, Section 6, the prevention protocol. It's all about proactive management. We've covered the etiology and triage, but why this matters most is how we apply it to stop heart failure before it even starts. This is your ABCDHF protocol. It's your ultimate checklist for modifiable risk factors. A is for avoiding tobacco and alcohol excess. B is for strict blood pressure control. C is for cholesterol and coronary disease management. D is for diabetes control. E is for exercise and a healthy weight. H is for heart rhythm management, and F is for follow-up and guideline-directed therapy. This proves that everyday lifestyle and metabolic targets are just as critical, if not more so in the long run, as the acute interventions we do in the cath lab.
Before we hang up our detective hats, let's lock in some high-yield pearls that brilliantly consolidate everything we've talked about. Remember your global leaders: hypertension globally and CAD in high-income countries. Keep your eyes on the reversibility champions. Tachycardia-induced and alcoholic cardiomyopathies can recover substantially with rapid intervention. And of course, never forget the progressive threats. Amyloidosis and genetic conditions require an immediate shift away from curing directly into device and transplant evaluation. I want to leave you with one final vital question, based on the framework we've just explored together. Knowing the sheer global impact of these etiologies, and knowing that the #1 global cause, hypertension, is highly modifiable with early intervention, how will you actively apply this knowledge to protect your patients' hearts starting today? It's not just about treating the failure, it's about anticipating it. Thanks so much for joining me on this explainer, and keep asking the right questions.